Hello, good evening everybody and welcome to the eUROGEN webinar programme. We're delighted to have you here with us this evening to listen to a talk about challenges in oncological treatment of retroperitoneal sarcomas. But first I just wanted to say a couple of words about what the Reference Network does. We're a network of about 43 highly specialised healthcare providers across the European Union, and the surgeons who work in those hospitals are working together to give highly specialised advice on patients with rare and complex urogenital diseases and conditions. If there's any people out there who are interested in accessing the Reference Network and receiving advice on a particular rare or complex condition, then please don't hesitate to contact us via our website. We'd be delighted to help. So to tonight's talk, it's an absolute pleasure and honour to have one of our Croatian partners here with us today, Nina Dabelić, and she's a clinical oncologist in the Department of Oncology and Nuclear Medicine at the University Hospital Sisters of Charity in Zagreb, Croatia. So without further ado, Nina, thank you so much for giving your time and your expertise this evening, and I will give you the floor. Thanks everyone for joining us.
Good afternoon, everybody. Welcome to today's webinar. I would just like to say that the co-author of this talk is Professor Anna Fröbe from my hospital. So we have no conflicts of interest. This is the presentation content, and we are going to start with the talk about retroperitoneal sarcomas. So these are solid tumors of mesenchymal origin. They are very heterogeneous. There are over 50 types, histological subtypes of sarcomas that can arise from retroperitoneum. They have distinct clinical, pathological features. They behave differently, and the response to therapy is different. They are rare, and collectively they account for approximately 1% of all adult malignancies when we talk about sarcomas, and the 5-year relative survival in localized disease is 80%, and in metastatic disease, unfortunately, only 15%. The patterns of metastatic spreads are usually to lungs, liver, and peritoneal dissemination may be present. So, as we said, soft tissue sarcomas in general are rare diseases, rare malignancies, and when we look at the retroperitoneal localization, it's even rarer, so around 20% of sarcomas arise in this area. The pathologic distribution is somewhat different from the extremity soft tissue sarcoma, and we usually encounter liposarcomas. However, other histological subtypes may appear, not only the ones that are mentioned here, but also every type of sarcoma virtually can appear in retroperitoneum. So, what is the retroperitoneal space? Of course, it's everything that is posterior to the posterior peritoneum. And because of this specific location, it is a clinically silent region. And usually we encounter large tumor masses, and there is a prolonged time to diagnosis. Also, there are anatomical restraints for obtaining R0 resections. What about the etiology? Often there is no defined cause, but sometimes we can see several factors that can be associated with the appearance of sarcomas, prior therapeutic radiotherapy, exposure to some chemicals, genetic predisposition, and some genetic alterations. What about clinical workup? Typically, Typically, these tumors are asymptomatic for a long time or have minimal symptoms, for instance, increase in abdominal girth, presentation with hernias, low back pain or abdominal pain, or sometimes bowel obstruction may appear. It is not rare that there are incidental findings on imaging for other indications, and as we mentioned, the diagnosis is late and we have large tumor masses at presentation. What about evaluation and workup? Medical history and physical examination is always the first step. In imaging, we do CT or MRI. It is worth mentioning that all retroperitoneal sarcomas are considered deep lesions. In differential diagnosis, we have to think of other malignancies and some benign lesions. Image-guided core needle biopsy is almost always preferred. So this biopsy is strongly recommended unless the imaging is pathognomonic, for instance, heterogeneous liposarcoma, or if we do not plan preoperative therapy. Otherwise, we always perform preoperative biopsy. Here you can see that some other types of tumors may arise in this area, like germ cell tumors, lymphomas, neuroendocrine tumors, desmoid tumors, and, for instance, benign schwannoma. So, soft tissue sarcoma in general, but especially, I would say, retroperitoneal sarcomas, should optimally be managed by a multidisciplinary team of experienced clinicians, including, of course, radiologists, pathologists, surgeons, oncologists, and pharmacists, and referral to a high-volume treatment center is highly recommended. This is the paper that is addressing this impact of reference centers on the outcome of sarcomas, and we see that in this NetSarc reference centers, what was mandatory was a presentation at the multidisciplinary tumor board and a second pathological review. And as a result, the quality of resection in reference centers, which was much higher than outside the reference centers, and we see that the R0 resection was achieved in much higher percentage in reference centers than the outside of them. Also, consequently, the survival, local recurrence-free survival and overall survival were much better in reference centers than outside referral centers. So this mandatory treatment in reference centers is a simple and a cheap way to improve overall survival in RPS patients. This is also an example why the MDT is important. This is a case of a Ewing sarcoma, a tumor that is extremely chemosensitive and radiosensitive. And if the patient is not presented at a multidisciplinary tumor board, sometimes these patients can go to surgery, but in fact, the first step in the treatment should be oncological treatment, and usually the first step is chemotherapy, and you see the massive shrinkage of the tumor post-chemotherapy in this patient with Ewing sarcoma, making it an operable tumor. What about the role of surgery in retroperitoneal sarcomas? It's pivotal. Complete tumor removal, surgical resection of a localized tumor with negative wide margins or R0 resection is the treatment goal, and of course, it's the only potentially curative treatment. We mentioned before that the tumors are large at presentation, that they are often adjacent to or encasing other viscera, and complex surgeries are needed, often with vascular reconstructions. and because of all that, wide resection margins are difficult to achieve. However, postoperative margin status is the most important factor contributing to long-term disease-free survival. So here you see some technical issues and difficulties in RPS surgery, proximity to critical organs, for instance, to major blood vessels, bone infiltration in some tumors, or some specific anatomic extensions that can change the surgical approach. And this is the preoperative imaging should be very good to be able to just assess the extent of the disease. So because of all that, unfortunately, most resections are R1, and there is a high rate of local recurrences. So what should be the extent or the aggressiveness of surgery is the matter of debate. We know that up to 75% of all retroperitoneal sarcomas related deaths are due to inoperable local failures. So aggressive extended resection was endorsed by Transatlantic RPS Working Group, and you see what adjacent structures were included in the resected area, and it usually stops at bone, duodenum, or major vessels. These extended resections consequently led to improved local control, and according to this paper, there was almost a 20% of overall survival improvement with more aggressive extended surgery. We're now going to address principles of oncologic treatment. You know that there are several types of oncologic treatment. The basic division is into local therapy, so that is surgery and radiotherapy. And when we talk about systemic therapy, that is conventional chemotherapy, but also targeted therapy and immune therapy. When we talk about goals or intents of the oncologic treatment, it can be with curative intent or neoadjuvant, adjuvant, or palliative. So what do we mean when we talk about adjuvant or neoadjuvant therapy? Adjuvant therapy is performed after the radical surgery, and with systemic or a local oncologic therapy, we try to achieve better local control and possibly better overall survival. With neoadjuvant therapy, we start with oncologic therapy. It can be, of course, systemic or local, and we try to shrink the tumor, to downsize the tumor, and then surgery is performed, and we see if the result of neoadjuvant oncologic therapy is pathologic complete response, near complete response, partial response, or sometimes we don't see a response at all. So now we are going to talk about radiotherapy in retroperitoneal sarcomas. We mentioned several times that these tumors at presentations unfortunately are huge, and negative margins are unlikely to obtain. And those close or positive margins lead to up to 60% of local recurrence. We also mentioned that these tumors are of different histologies, and some histologic subtypes have higher affinity for local recurrence and some for distant metastasis. So in this paper, we see that the highest affinity for local recurrence is in liposarcomas, whereas in leiomyosarcomas and soft fibrous tumors, it is low. Also, after 15 years, the pattern is, I would say, similar or the same. So is there a rationale for radiation therapy in retroperitoneal sarcomas? The goal can be radical therapy, downstaging, improving local control, but all of that should be done with acceptable toxicity. Unfortunately, data on the benefit of radiotherapy in RPS are scarce. There is no clear role of perioperative radiotherapy in retroperitoneal sarcomas. There is no level 1 evidence. The data are mostly non-randomized, and there are retrospective studies with conflicting results. Often extrapolations from soft tissue sarcoma extremity data about effectiveness of radiotherapy perioperatively is done, and that is not good because these tumors are in fact different. Recently, the results of this TRUST trial were published, and this study unfortunately showed negative results on the value of preoperative radiotherapy in RPS. The toxicity profile should be acceptable, and we usually deal with acute gastrointestinal toxicity. However, if done properly, preoperative radiotherapy is tolerable, and quality of life improves over the course of 12 months. So, what about timing of radiotherapy? Preoperative radiotherapy is preferred in a large portion because the doses of preoperative radiotherapy are usually around 50 grays in 25 fractions. The question is it sufficient for the sarcomas? We hope that it might be effective and tolerable because higher doses lead to higher toxicity. Post-operative radiotherapy should be delivered in higher doses, and there is the question of and the issue of toxicity, and post-operative radiotherapy in retroperitoneal sarcoma should be avoided. Intraoperative radiotherapy can be performed as a boost, usually after preoperative radiotherapy, but there are accessibility issues, and special machines are needed. So the standard machine is linear accelerator. There are potential benefits from proton beams and heavy particles, but they are not easily accessible. They are present in a small number of centers. There is always thought about concomitant or sequential therapy with conventional chemotherapeutic agents or small molecules. If done, it should be done sequentially because of the toxicity. This is the data extrapolated from the extremity STS about the benefit of the combination of radiotherapy and systemic therapy, and in extremity sarcoma it is clear, but we said it is in fact an error to extrapolate this data without further studies and without further efficacy proof. So what about the specific site? We said that unfortunately these recent results from TRUST study were negative, and this is this ERRTC clinical trial, or so-called TRUST, that was published in autumn last year about preoperative radiotherapy plus surgery versus surgery alone for patients with primary retroperitoneal sarcoma. It was a multi-center open-label randomized phase 3 trial. Patients, 266 of them, received a tumor dose of 50.4 grays in 28 fractions preoperatively, and in all patients, the median abdominal recurrence-free survival was 4.5 months in group that received radiotherapy with subsequent surgery versus 5 months in only surgery group. So the conclusion is that preoperative radiotherapy should not be considered as standard of care treatment for retroperitoneal sarcoma. I will show you the subgroup that was also presented in the paper of the patients with liposarcoma, because in those patients, twice as many local recurrences in operation-only group versus radiotherapy plus surgery group was established, and there was a 10% absolute abdominal recurrence-free survival benefit in favor of addition of radiotherapy to surgery. However, the study was not designed nor powered to analyze histological subgroups. However, from these results, we may conclude possibly that liposarcoma patients and also patients with low-grade retroperitoneal sarcomas may benefit from preoperative radiotherapy as opposed to patients with leiomyosarcoma and high-grade RPS. So we also have to take into account patients' characteristics, their age, their lab results, comorbidities, performance status, and it is important to say that more is not always better when we talk about therapy, and sometimes we decide to refrain from therapy, but it should be an MDT decision. And in the guidelines and recommendations, preoperative therapy, radiotherapy, and also systemic therapy, and also intraoperative radiotherapy is an option that should be considered. However, the data is, as we saw, not strong, and postoperative radiotherapy should not be administered routinely. Perhaps in highly selected patients in R1 or R2 resection, it can be considered. And unfortunately, European guidelines date from 2018, and they address only soft tissue sarcoma in general. So I think that these data cannot apply to retroperitoneal sarcoma. What about systemic therapy in retroperitoneal sarcomas? Well, the candidates for systemic therapy are patients with unresectable tumors, meaning those that involve vital structures, tumors whose removal would cause unacceptable morbidity, and also medically unresectable patients, those who are not medically fit for resection. Also patients with tumors that are sensitive to chemotherapy, where downstaging or better tumor control is a goal, are candidates for systemic therapy, and of course patients with stage 4 disease or distant metastases. We mentioned that sarcomas, so also retroperitoneal sarcomas, are heterogeneous group with different histologies, and some of these histologies have a tendency of local recurrence and some for distant recurrences. So these are 3 examples of how large therapeutic challenge those tumors can be. You see on the left-hand side the 72-year-old female with high-grade sarcoma, diffuse metachronous pulmonary metastasis. Then in the middle, the imaging of a 62-year-old female with dedifferentiated liposarcoma, which is inoperable, and with pan-abdominal disease. And on the right-hand side, the 55-year-old female with leiomyosarcoma and multifocal metastatic relapse. So what are the key determinants in selecting systemic therapy for patients with locally advanced or metastatic soft tissue sarcoma? Histology, as we mentioned before, because they are chemotherapy sensitive and chemotherapy resistant histologic subtypes. Also, response to previous systemic therapy is important, because if we have a patient who progressed to a previous regimen and second line, we can change therapy, or we can observe patient if the patient is asymptomatic And of course, a clinical study is always a preferred option if available. Patient performance status is also very important. Fitter patients may be candidates for more aggressive therapy, and of course, treatment goals. So in general, in this advanced or metastatic disease, the goal is improvement of quality of life and extended survival. If we have a marginally operable disease, downloading to operable disease is a goal, and we tend to do more aggressive therapy in those situations, as well as when we need a rapid palliation in symptomatic patients. So, what principles apply to systemic therapies in RPS? We talked about the goals of systemic therapy. What about timing? It can be neoadjuvant or adjuvant therapy, as mentioned earlier. So what are potential advantages of neoadjuvant systemic therapy? There are no delays in the initiation of therapy. We can have an early indication of the effectiveness of treatment. Also, there is an immediate treatment of possible micrometastases without delay. We can have a possible quick improvement in responding patients, symptoms relief and tumor shrinkage. Then cytoreduction and downstaging lead to less extensive surgery, and there is a highly likelihood of achieving negative surgical margins. Patients have when the therapy is given as neoadjuvant, a better performance status because they're not operated yet, and there is an intact vascular supply, and there is no risk of negative impact of chemotherapy on wound healing. What are possible disadvantages? Non-responders may become inoperable. There may be possible worsening of performance status with negative implications on surgery, and we mentioned before the lack of randomized prospective data on efficacy. So this is the paper published last year in Cancer that tried to address the role of neoadjuvant systemic therapy in high-risk retroperitoneal sarcoma. And there were 158 high-risk RPS patients involved. The study was retrospective. The median of 3 cycles of neoadjuvant systemic therapy was given, mostly anthracycline-based regimens. None of the patients achieved complete response. Partial response was achieved in 23% of patients, and stable disease in 56% of patients per RECIST 1.1 criteria. So what would be the recommendations nowadays based on the current data of the neoadjuvant systemic therapy? Well, multidisciplinary discussion of all newly diagnosed cases is a recommendation. Prior biopsy is almost always mandatory. We can consider neoadjuvant chemotherapy in high-risk cases, high-grade borderline resectable patients or tumors, when we have uncertain or suspicious distant metastasis or multifocal disease, and when patients are fit to receive anthracycline-based therapy, usually doxorubicin plus ifosfamide. It should be, the integral imaging should be timely, usually every 2 to 3 cycles of chemo. So if stable disease or partial response is achieved, then we continue therapy until completion of 6 cycles and then go to surgery. Neoadjuvant systemic therapy should be given prior to preoperative radiotherapy, and the STRUSS-2 clinical trial is ongoing, and this clinical trial is addressing the issue of neoadjuvant chemotherapy, and we hope that in a prospective trial, so we hope that we'll have the answer to the question of the effectiveness of neoadjuvant therapy. What about adjuvant systemic therapy? There are no prospective clinical trials in RPS patients. There are large variation in practices, even between well-established and high-volume centers. Current evidence is based on data from extremity sarcomas, as I mentioned before, and does not take into account histology. Chemotherapy agents that are used are possibly not optimal. Kidney function postoperatively is often compromised due to nephrectomy that is performed in a large proportion of patients. This potential questionable benefit of adjuvant systemic therapy should be discussed in the context of treatment-related toxicities and the quality of life impairment. Decisions should be made on a case-by-case basis in a multidisciplinary setting. So, in conclusion, adjuvant chemotherapy is generally not recommended. So what about the systemic therapy protocols? Well, there is this approach, one size fits all, which comprise doxorubicin, ifosfamide with mesna. It is usually first line. There are some exceptions to the rule regarding different histologies. And there is also histology-driven systemic therapy, as you may see here, because we know that trabectinib or pazopanib or eribulin are more effective in some histologic subtypes. So also the question of concomitant or sequential systemic therapy with radiotherapy is raised, and the efficacy is always higher, but at the cost of higher toxicity. And we are eagerly awaiting the results of the STRESS-2 clinical study, which I mentioned before. Patient characteristics are always important. For instance, if we have an asymptomatic patient with no response to first-line therapy or progressing to first-line therapy, sometimes we refrain from further therapy. What are the future perspectives in retroperitoneal sarcomas? Well, first of all, there is a great need for clarification of the role and timing of radiotherapy and chemotherapy and systemic therapy in general in this setting. So the role and timing of these therapies is going to be hopefully addressed and answered in ongoing prospective clinical trials. Perhaps the way for the future is the fact that there are some genetic alterations in sarcomas that can be potential therapeutic targets. So a lot has been said about NTRK gene fusions as treatment targets in the last couple of years, and about the drugs that can be highly effective in patients that have these NTRK gene fusions, like larotrectinib and entrectinib. Unfortunately, these gene fusions are present in only around 1% of sarcoma patients. Immunotherapy, which led to a revolution in oncology in recent years, unfortunately, in sarcoma still has modest efficacy. And now, at the end, I'm going to say a few words about patients with sarcoma in Croatia. We're a small country. And the cancer incidence overall is a little bit over 24,000 per year. Croatian Cancer Registry has, unfortunately, information according to cancer site predominantly, not histology so much. So the estimates about the soft tissue sarcoma and the retroperitoneal sarcoma is that in Croatia annually we have around 35 to 40 patients with retroperitoneal sarcoma. In our department last year we treated only 12 patients because of the rarity of this disease in some patients and in local centers. So what are available facilities in our department at Sestre Milosrdnice University Hospital Center in Zagreb? We're the second largest sarcoma center in Croatia, one of the university hospital centers with radiotherapy units, and there are some regional hospitals. We would like the patients with sarcomas to be referred to larger centers, but unfortunately that is not always the case. We have access to all necessary diagnostics, CT, MRI, PET-CT, image-guided biopsy. We have skilled pathologists that are using immunohistochemistry and genetic analysis, and experienced surgeons. Decisions are made through multidisciplinary tumor board, and we've performed radiotherapy, pre-operative and post-operative. We don't have a facility to do intraoperative radiotherapy. We do chemo and targeted therapy in sarcoma patients. In other settings, we also do immunotherapy, and we can refer patients to rehabilitation, psychological support, and reintegration to society. So my take-home messages would be that retroperitoneal sarcomas have various histologies. So these various histologies lead to different biologic behavior, different response to therapy, clinical prognosis, and outcome. They are rare, as you saw earlier. Unfortunately, they are large tumors at diagnosis. They present great challenge in surgical treatment and in radiotherapy. There is a great unmet need regarding medical therapy and multidisciplinary management, expert collaboration, tailored treatment strategies in high volume centers is the way to achieve better outcomes, but we still have a lot of work to do in this specific setting. And with that, I would like to thank you for your attention.
Thank you, Nina. So yeah, if anyone's got any questions, please don't hesitate to ask them now. If anybody just should also say a few things, I should say. If you don't ask a question now, you think of one later, please don't hesitate to contact me with it and I will pass it on. So in terms of that as well, we were recording the webinar, so it will be available for rewatching on both our GoToWebinar platform and also on our YouTube channel from tomorrow. Hopefully, if I have time to get all that sorted, it should be from tomorrow at some point. But please keep an eye on it. For all our other webinars, please check out our website as well, the eUROGEN website. There's a link on the front of that to the page with all the webinars on that are upcoming for the first 6 months of this year at the moment. And also the website explains a lot more about what Michelle said at the beginning around the services we offer and how to access those. Yeah, so no questions at the moment, Nina, so you're getting away with it here. That's good. But yeah, let's give everybody a couple more seconds just in case. Something could be quite long at times. But yeah, I also send out the link to the video recordings tomorrow as well to everyone who registered. So you will receive that. You also receive a survey, a request to fill in a survey tomorrow. It's obviously not compulsory, but I would say if you could spare just a few minutes to do that, it'd be really helpful for us. Just helps us to kind of understand kind of what you thought about the webinar technically and kind of in terms of content, and it helps us to think about how we can improve going forward. So thank you if you could do that, that'd be great. I'm trying to think what else I usually say. Yeah, so okay, no questions. Okay, that's fine. So if anyone has to think of anything afterwards, then no problem. Please just don't hesitate to get in contact with me. Yeah, I think just like give it a few more secs, and then thank you again, Nina, for the presentation.
You're welcome.
And yeah. I said we'll get it available tomorrow for everyone to watch. I think we'll kind of leave it there, I guess, if no one has any questions for now. But thank you all again. Thank you again, Nina. Thank you for everyone for attending. So look out on our website for the next one. Our next webinar is on the 30th of March, I think. It's also on a Tuesday at 6 o'clock. And then we have 2 coming up in April and 3 coming up in May as well. I sent all those details on the website. So thank you. If no questions, I'm going to end the webinar now. So thank you very much, everyone. Goodbye.
Thank you and goodbye.